You're watching Capitol View, Sunday morning talk focused on the political scene in Arkansas.
Welcome back to the program. Joining me now is Dr. Joe Thompson. He heads the Arkansas Center for Health Improvement. Good to see you, sir.
Good morning.
Yeah, it's been a while since we've had a chance to visit face to face. It's good to see you.
Glad to be with you.
Yeah, you look good. You look like you've been surviving the 125-degree heat.
Survive the summer, ready for the fall.
You're probably ready for winter, aren't you?
I'll take the fall. The fall's beautiful.
You and I are both Hendrix College graduates.
Correct.
I met the new Hendrix president this week, Dr. Karen Peterson, super sharp.
I've not had that opportunity. Look forward to it.
We will have an interview in a couple of weeks on air with her that I think you'll find interesting and engaging.
Great.
Your father was a professor there.
He was.
I know. I got to remind people of all these things. All right, big news this past week on the federal level in that the Biden administration rolls out 10 drugs that are going to be able to be negotiated in terms of pricing for the Medicare program. And this is kind of a big deal. Tell me, how big of a deal is this?
This is a very significant change for the federal Medicare program. Medicare is what we care for elderly in our nation. Since 1965, when Medicare was first put in place, it did not cover prescription drugs. The Part D program that went in place after the turn of the century did cover prescription drugs, but it did not allow the federal government to negotiate price on prescription drugs. So this is the first time Medicare, our federal insurance program for the elderly, has been able to negotiate price with pharmaceutical companies for now 10 drugs that are some of the most expensive drugs for people to pay.
You anticipate there will be other drugs that will eventually get worked into this?
I think the intent is for there to put capitalism, competition, into the drug pricing of pharmaceutical companies in their negotiations with the federal government. There are lawsuits by a majority of the pharmaceutical companies against the federal government to prohibit this from happening. So we've got a legal process, but we've had a negotiation process for the first time going forward.
I just say shocked that there's gambling here in this casino. So, yeah, the legal action there. Let's talk about, I think you can probably navigate this in pretty neutral terms here. This has been a huge political debate in Washington, D.C. for decades, really, this whole possibility of negotiating these prices. Kind of what have been the forces at work in that?
I think the major forces at work are commercial for-profit entities that frequently benefit from new discovery that happens in our academic institutions and our research labs across the nation, that they turn it into a drug that unfortunately individuals have to have, and so they'll pay whatever it takes. The federal government has paid whatever the pharmaceutical company asked, and now for the first time we're actually having a negotiation about what that should be. Other countries don't do that. Countries around the world do not pay what America pays for these pharmaceuticals.
And why is there a difference between countries like that? I mean, that seems to not make as much sense to me.
It's been a political process. The advocates for the pharmaceutical companies, the lobbyists, have had laws and regulations in place that prohibit our federal government from negotiating where other countries negotiate fairly successfully.
Gotcha. All right. Medicaid disenrollment, another hot button topic. We're about at the end of month 5 of a 6-month process to take people off. Give it a little bit of background for people that don't understand why we are going through this whole process of redetermination.
So Medicaid, aid for the poor, has been a federal-state partnership also since 1965. When COVID hit, the federal government made a deal with states saying, if you will not disenroll people during the pandemic, we will give you extra federal money to run your program. And our state, like every other state, said, yes, we'll take extra federal money. And so for over 3 years, we enrolled people in Medicaid, but we didn't disenroll anyone from Medicaid. Last year, as the pandemic came to an end, we still have COVID, we'll come to that in a moment,
right.
But as the pandemic emergency came to an end, the federal government said you can now redetermine if individuals are still eligible, and we started redetermining and disenrolling people that were no longer eligible.
And that has been a significant number of people, and there are a variety of reasons why they might not have been re-upped with their Medicaid. We might have lost touch with some of them may have moved away, some of them just may not have turned things back in, some of them may have moved up the income food chain, which takes them off of Medicaid. Where do you kind of see most of the shift coming?
So Medicaid is an income-determined eligibility. A certain level of income, 138% of the poverty level, makes you eligible to be on Medicaid with no premiums for your health insurance. Over the 3 years, the state and other states enrolled lots of new people didn't disenroll anybody. We now have the lowest unemployment rate that we've ever had. So as the state goes through this, we're going to find individuals whose income has increased, so they're no longer eligible. But we're also going to find people who still are eligible because of their family size or because of their circumstances that need to stay on the program. So we're now entering the 6th month. 6 months is what the state of Arkansas determined they would do this in. And we have individuals that have been disenrolled. Probably we have many that were disenrolled appropriately because their income was elevated, and we have some that were disenrolled because they couldn't navigate the system, and so we're going to have to re-enroll those over the next few months.
What do you think of the process for re-enrolling those folks that were disenrolled because they can't navigate the system? The state has put a lot of effort into this. I think there's been almost a whole year's worth of preparation for this. To me, it seems like when you come into your point of care in the health delivery system, the emergency room, your doctor's office, that's probably when you learn you don't have health insurance for the first time.
People frequently don't think about health insurance as a critical need, but it is. It's the #1 cause of bankruptcy in the United States. And what happens is when people go to the emergency room, go to the doctor, need care, that provider needs to get paid, and it's frequently paid by a third party, either a health insurance plan or Medicaid. As we've disenrolled these individuals, those folks whose income is increased need to get enrolled and insured on the health insurance marketplace. Many of the individuals that paid nothing for Medicaid, their income's increased, they can get a federal subsidy where they almost pay nothing for the same insurance coverage, but it requires action on their part, and that's the challenge. I think all of us get challenged each year doing our taxes. This is doing your taxes with the state government, and this is a challenge.
I think one of the things that I love about you the most is that you're so data-driven in your decision making and in your analysis of things. What do you see in terms of data, or will we see at some point data that shows here are 132,000 people that moved up because of their income level. Here's another 17,000 that should be in here but aren't. I mean, are we going to see some data that kind of backs up the hypotheses that are behind this disenrollment?
Well, over the course of the 3 years of the pandemic, our Medicaid rolls blossomed to 1.1 million, a little over. So 1 in 3 Arkansans were on Medicaid at the end of the pandemic. We've now disenrolled about 300,000 people. The issue is, how precise were we in those decisions? Did we disenroll the right people? People whose income went up, they've got another source of insurance, they should pursue that, versus those that are still eligible and just couldn't navigate the system and complete the paperwork. We'll see that over time. It'll take a few months. Luckily, in our state, when people are Medicaid eligible and they present to a provider, there's some retroactive eligibility that the provider can get paid for the previous 30 days. But this is an active step that all Arkansans, if you get a letter saying you're no longer covered by insurance, take action to get covered, either by re-enrolling in Medicaid or by going to the health insurance marketplace and getting a private policy.
Let's update on COVID. Are we still COVID-19 and its variants, or do we have a different COVID number? Are we going to get a new COVID number soon? How does that work?
Well, all the variants have a name, but I think they're all progeny of COVID-19. Okay. It's like we have a new family in the neighborhood, and it's not going away.
And they're related to the COVID-19.
They are all related to the parent COVID-19.
Where do we stand right now? There seems to be, anecdotally at least, an uptick. I don't know if we have as much data to track it as we were during the height of the pandemic.
We're not tracking COVID-19 infections like we were during the pandemic. I think anecdotally, if you talk to people, more and more people are getting infected now. Hard numbers, our hospitalizations are going up. We have 160 hospitalizations in a recent week. That's 20 hospitalizations a day. This is a virus that is going to stay in our environment. It's a virus that is rapidly changing. We have new variants. It's a virus for whom we are developing vaccines that do work, but our protection as a community is falling off. So we need to remain vigilant for individuals that have an immune problem, have cancer, have a family member that are at risk. You need to recognize that COVID is still present and that we're having an uptick in infections.
How effective are the vaccines that many of us took during COVID-19? Sure. And all of that period? It's got to have worn off or be pretty close to wearing off by now.
So the challenge with this tricky new virus, is that it continues to mutate. It continues to change its appearance so that our immune systems don't recognize it as easily, and therefore it has a new opportunity to infect us. The vaccines that are coming out this fall are very good against, I think, the XBB as reported. They were developed to be specific for the virus that was present this summer. We have some new variants that we don't know how effective the vaccine's going to be, but the pharmaceutical companies, the vaccine manufacturers continue to evolve their vaccine as this virus continues to mutate and represent a new threat.
As a doctor in your position with ACHI, do you think that we are enough on top of this in terms of the science to be able to address the rapid mutations that are coming?
I think this virus we are not yet in control of. Unlike the flu virus where we kind of know its pattern and we can develop a vaccine in advance, this virus continues to mutate, not necessarily on a calendar year cycle. I mean, currently the subvariants represent a lot of the infections that are happening, and we don't know which subvariant. You know, there's three things that are important. How infectious is it? How deadly is it? And how much does our immune system recognize it? Those are the three things, and with every new mutation, we have to reassess those three risk factors.
All right. I got to end it there. I think we could talk about COVID for another half hour, but they don't let me devote the whole show to that. I'm sorry. You'll have to start your own program just to do that.
Thank you very much for having us.
Dr. Joe Thompson, thank you. Always good to see you,
Good.
sir. All right. We're back with more after this.